Good morning. I see that it's 10 a.m. I want to welcome you and thank you for joining us today for our webinar on streamlining access to control data at NIH, tackling challenges and identifying opportunities. I believe we have over 500 people registered and almost 200 people here attending today, and I'm pleased to welcome you all. I'm Susan Gregorick, the Associate Director for Data Science at NIH, and I'm joined by my colleague, Dr. Patricia Flatley Brennan, the Director of the National Library of Medicine here at NIH. Dr. Brennan and I co-chair an internal NIH working group that is hosting this webinar, as well as a number of activities this summer. The goal of the webinar today is to explore perspectives on the challenges and opportunities in accessing controlled data in repositories stewarded by and sponsored by and supported by NIH. NIH stores and facilitates access to many different types of data sets, both open and controlled access, all with the goal of accelerating new discoveries, thereby maximizing taxpayer return on investment in the collection of these data sets. As data and access requests increase, new repositories are established and new mechanisms for providing access to data are developed. It's apparent that opportunities remain to improve efficiencies and harmonization among repositories to make NIH-supported controlled access data more findable, accessible, interoperable, and reusable, fair, and to ensure appropriate oversight when data from different resources are combined. While these trends are enabling data sets and data types to be combined in new ways that advance science, data sets and data types that may or may not be controlled access may, when combined, create inadvertent re-identification risk. This is the first in a series of events this summer on the topic of streamlining access to controlled data. Today and throughout the summer, you will hear more about these activities from Dr. Brennan at the end of the webinar today. During and after each talk, you will be able to submit questions in writing through the Q&A button at the bottom of your screen, and I will be moderating the Q&A session after each talk. We will ensure that there's plenty of time to address your questions. With that, I'd like to introduce our first keynote speaker, Dr. Richard Hodis, who has directed the National Institute on Aging at the NIH since 1993. Dr. Hodis' leadership has seen the growth of the NIH budget to over $3.5 billion, reflecting an increase in the public's interest in aging. Dr. Hodis has devoted his tenure to the development of robust, diverse, and a balanced research program focusing on the genetics of biology of aging, basic and clinical studies aimed at reducing disease and disabilities, including Alzheimer's disease and related dementias, age-related cognitive changes, and investigations in the behavioral and social aspects of aging. Dr. Hodis is a graduate of Yale University. He received his PhD from Harvard Medical School, and he completed his training in internal medicine at the Massachusetts General Hospital in oncology at the National Cancer Institute. He is an influential scientist in and contributor to the field of immunology, having authored more than 250 research papers. Thank you so much, Dr. Hodis, for joining us today. His presentation is entitled Opportunities for Advancing Research Through Better Access to Controlled Data. Welcome.
Thank you. Thank you, Susan and Patty, for this opportunity. And I hope we're set visually. Appreciate the invitation to speak with you. In fact, it was a useful opportunity for me and for staff to consider and overview the accessing control data and a little bit of the history of where we've come to, some solutions found and some challenges that remain. As a way of schematizing the issue, I use this first slide, which illustrates the challenge now when we have multiple projects, each of which involve data in this model for IRB approved informed consent. They have in common the collection of data, the generation of databases, which may be administrative, and in this case, administrative refers to some of the non-research, non-clinical databases such as Social Security or CMS, clinical databases, any other sorts of databases, in common then with an interest in somehow finding the way in which they can be identified, hashed in order to identify unique participants. And then the lower half of the scheme you see there, a data pooling, harmonization, and integration. So if we focus first on informed consent, it sounds like it ought to be a straightforward area, but I'm sure those of you who've had experience recognize that the shared experience that is not. The issues include those of constrained consents, which may differ in different individuals in different studies, among those which attempts are being made to harmonize and co-compute. Issues include the constraint of consent and then withdrawal of consent. So in terms of non-uniform informed consents and their constraints, I'll take some of the examples that we've come across initially around the area of genetics for Alzheimer's. So these may relate to individuals who've been consented only for Alzheimer's research, other forms of research. It may have to do with the source of the requestor. So in some cases for nonprofit or profit only. As the example I'll take here, the National Institute on Aging Genetics of Alzheimer's Disease Data Storage Site, or NIAGADS. We have found through excruciating at times assessment of informed consents when we try to pull data into a form that could be co-computed, the large number of different constraints across studies and surveys.
Excuse me, Richard, your voice is cutting in and out for some of the participants, and I've asked our ORISE colleagues to check into that. But if you could also just check your microphone, make sure it's close enough in.
Okay, I apologize. I'm working from the laptop internal, and I hope that's not going to be a problem. I'll use the old-fashioned mode of coming closer and speaking louder, and please let me know.
I appreciate that. Thank you.
So you can see here that in addition to the general research use agreements with the breadth of which we're trying to achieve these days, we have many other of the variations you can see here. Some are disease specific, only for neurologic disorders, others for studies having to do with aging only, neurodegeneration. There are disease independent use modifiers, general use, but those which limit to nonprofit, and some 15% of our consents are like that. Some are consented only for methods development, others for genetic research only. And we have literally piles of up to 20 different forms of individual consents that need to be constrained, originally done manually, to pull us together. So in current times, of course, prospectively, we're working at consenting through general use to minimize problems, but this won't go away retrospectively. And Patty, let me ask you, is the audio okay now or acceptable, I hope?
It's much better to me, and anyone who wants to put a thumb up and let us know or type in a question if there's a concern, please continue to do. We'll monitor that.
Thank you. So actually, let me elaborate further here on informed consents. I'll give you some examples of how we have dealt with informed consents as policies have evolved over time, very much dependent upon the IRB and then the consent itself. In some cases, with recontacting, we're able to reconsent. In other cases, not. So we have, for example, historical epidemiologic studies that will probably never have their consents changed. We're forced to therefore look at individual participant level at times to decide which data can be pooled with which others in the studies that we do control. In terms of withdrawal, it's important that individuals are able to withdraw consent to share information at any point from a repository. And this is one of the reasons, maybe that's the one that comes to mind first, for why personal identifiers are important, why they're maintained in NIAGADS, although maintained separately from the shared data sets themselves, because of course we need to have that information in order to honor requests for withdrawal of consent. The withdrawal applies only to future data sharing. We can't affect data sets and analyses that were carried out prior to withdrawal, and that's understood in our original consenting of individuals. If we look at a couple of the case studies of how things have evolved over informed consent, the Baltimore longitudinal study of aging is the oldest longitudinal study of aging in the United States. It's run by the intramural program of NIH, was established in 1958. And for the first years, up to about 2010, there was apparent simplicity in consent. It was simply an overall consent with no mention of specific choices. But as our IRBs changed, and literally from one IRB to another that was utilized, and then from the practices within an IRB, things evolved. So from 2010 on, we had informed consent that stated, for example, my specimens and data may be stored and used for future research, or I consent for DNA collection. Over time, however, as we approached 2020, it was judged by the IRB that this was not sufficiently explicit to indicate whether data could be shared with investigators other than those involved in the Baltimore longitudinal study on aging. That led to, at times, requisite collaborations, which we didn't think were essential but were required in order to have consent apply. So more recently, we've moved to my specimens and data may be shared with other researchers. There may be any number of things we're not anticipating now, but examples of how we do our best to evolve to make the data as freely available from criteria of informed consent. If we move then to the way in which our different databases are constructed and how they can be collected and converged or co-localized for calculations. So again, there are multiple forms of databases. I mentioned the administrative type that are not formulated for research purposes primarily at all. Clinical databases, others, including some that employ rather sophisticated omics data these days. So what's important is access to them, interoperability, privacy and identifiability, and of course, we'll talk a bit more about this, maintenance of a workspace in which data can be analyzed. So for the data sets that come from multiple repositories, in NIH, for example, to assure the processes we've talked about, we needed a comprehensive catalog of databases so we know where they exist, harmonizing metadata, common data elements when possible so these data can be accessed. Accessibility means we need to have consistent language for consent and data use limitations. We've talked some about that. And then also streamlining the review for approval by data access committees. Interoperability, making the data more readily combinable by harmonizing data formats, and then reusability, important for not just the current, but for foreseen and unforeseen future events in which we want to maintain privacy, but also have ability to reuse, recontact, re-identify over future purposes as yet not entirely visualized. So in terms of the interoperability, the need for our ability to work with data, illustrated here are some of the prominent themes. We need to co-locate data, and without question, the availability of the cloud has made this possible in a way that we wouldn't even be discussing a private cloud, for example. So it enhances the ability of data to have enriched scientific impact by their convergence, by merging data sets. It involves being able to discover, it involves the need for commonly used software services as well. And then importantly, someone needs to provide, and we'll talk about how that provision works, a platform for supporting the repeatable access to data, for facilitating interactions across projects, and for monitoring versions of the data sets so they are current, and then scalability too, to scales that not were envisionable just a few years ago. An example of some of the challenges we faced here in bringing data to a common place for calculation for the not so distant past when we would have data from studies supported by NIH, but different studies supported from the same or different institutes. We had circumstances in which a given individual investigator had grants from 2 institutes for 2 different studies and was unable to cross-compute across his or her own data, in fact, because of limitations in interpretation by IRB for data sharing. We've worked very hard, and I think the massive advance has been to use cloud and consensus. The most general solution has been that in which data are brought to a cloud for computation, for analysis, but never reside there with any permanence. That is, when the task is done, when the analysis is done, they revert to their origins, and so there's never an agreement to actually transfer in perpetuity the data. This has solved a lot of our problems, though not all. It's at times cumbersome, but it's been an enormous advantage over previous, for example, federated approaches to analyzing cross data. The advantages, I think, we all appreciate by bringing data from multiple sources, and examples here of some of the different kinds of data. Genetics data, which is a starting point, but then omics data, the gene expression, the metabolomics, the metabolic pathways that are downstream of genetics themselves. Imaging data, very high density data themselves, and also very critical to a lot of analyses. Electronic health records, as well as some of the data I mentioned from administrative data sets. This enables analyses, of course, research questions that could not have been approached by a single study with a single data type. It's important to have methods in place to preserve privacy, allowing linkage models, the data encryption and synthetic data, another variable that we found at times to be useful beyond what I think we envisioned some years ago as a way of preserving privacy, preventing identifiability, but still having legitimate calculations upon data. And as we're approaching more and more emphasis on machine learning techniques, of course, having the format for these pooled data available and accessible to this. So as an example of some of our successes in more challenging cases, I've illustrated a few of them here. NIH funded studies that have linked CMS, Medicare, Medicaid data Those are clearly closely guarded for reasons of confidentiality and privacy. Among in the first bullet there is an example. We've linked some of our population-based studies, the Health and Retirement Survey, which is one example. It's a population representative survey of some tens of thousands of older US citizens. Sampling pools can be usefully maintained by reference to CMS. We also are able to use a long-term follow-up from CMS data as part of our studies. But we'll note, in fact, you can see in that sort of footnote down below, not the methodologies for preserving privacy have to be tailored to some of these usages. So it may not be clear to all, but for linkage to CMS and in fact for Social Security as well, we use PIIs rather than privacy preserving linkage because, for example, CMS does not allow for any of our contracts to upload tokens to the data set. So we find other ways to provide access to individual identifiers. It can be through a Social Security number. It can be through a wet signature requirement. We have to live with requirements from other agencies, other data sources currently, but so far I've been successful in doing this. We managed to link NIH-funded clinical studies with CMS data in very useful ways. Some of them are illustrated here. They've included pragmatic trials that were carried out through the NIH Data Collaboratory, through PCORI, and here we are actually able to follow the long-term consequences of interventions in our clinical studies by linkages to CMS in increasingly near real-time data. And CMS has been, over the years, a collegial partner in making this work. As a more recent example of the way in which these data analyses have been useful in near immediate or real time, as COVID-19 evolved and as COVID-19 vaccines first became available, we took advantage of the fact that we had networks in place in which we were able to monitor across a large fraction of the nursing homes across the country, large numbers of nursing home residents, and in those populations, to monitor for adverse effects or not in the very early days when vaccines were spread beyond the initial clinical trials, and provided data that were published in days and weeks that were extremely useful. Now, as we look to go beyond these networks and look still further in ways in which we can monitor with linkage to sources such as Medicare, Medicaid, or other providers, these linkages are proving extremely useful in letting us understand the consequences of interventions, deal with them, and modify in the important time frame that's necessary for implementation and modification of these studies. So just to touch upon the fact that we're talking about the richness and value of maintaining a site in which data harmonization, integration, calculation can be assessed. These can be provided through NIH by targeted FOAs. They can be provided elsewhere. In addition to those that NIA and other institutes are providing, we're happily interacting with other potential partners who are engaged in the same space, for example, with Gates Ventures and an Alzheimer's disease initiative there, in which they are also looking for the right ways to develop tools to bring cargo into a safe space, to allow interoperability and calculation, and then to return data and the products of research. So this is not free. It requires an investment, sustainability of that investment as well. Can be done through NIH or institute funding centrally or diverse cooperative agreements, contracts, but many of us are trying to understand what mechanism is most effective for providing something that we know will be there in the years to come as technology and needs continue to evolve, but as the overall requirement is going to sustain. And importantly, just to note in this final slide.
Your voice is clear.
Again?
Oh, okay. I was just saying, your voice is clearest when you're closest to us.
Okay. So in terms of data analysis and methods, important that we have shared means for data analysis so that reproducibility, which is the cornerstone of our work, can evolve. And just to provide an example of the way things are evolving, some journals, Nature as a subset, for example, here, is requiring peer review and documentation of the codes, the algorithms, the software. Others suggest but don't require it. And this is going to be another ancillary to our own efforts to try to bring data maximally interoperable and overcome some of the barriers we've talked about. So with apologies for the audio challenge, let me stop here, and happy to engage in discussion that's of interest or useful to any and all of us. And again, I appreciate the opportunity for us at NIA to do some inward thinking and then to share our thoughts with you.
Thank you so much, Dr. Hodes. That was a fantastic talk. And we have a number of really interesting questions. I'm going to read the first one, which is, working in the cloud, have you found that researchers can download the cloud data and use it in a folder? And when they download the data, they could hypothetically share that data with others. And how would you deal with that particular scenario?
Yeah, this is at the heart of some complexity. So yes, the outcomes of analyses, of course, have to be shareable. They're intended to be publishable, but the primary data that were the products are not shared because they don't reside in a shareable space. And you know, I think it'd be naive to think that that's a clear-cut distinction always in terms of what it is exactly of process data that can be shared and what is not authorized for data sharing. So I think that's hit upon a very important question. We have workable operations, but I think that's going to be an evolving challenge.
Thank you. That's wonderful. There are a number of participants who are interested in references for privacy-preserved record linkage models and encryption linkage techniques. Would you like to answer that? And we can certainly talk about what we've done here at ODSS as well.
You know, I think, Susan, that falls back to you because, as you know, we've worked very closely with you, with Patty, and this group. They're central. I don't think we've had innovative means that are independent of what NIH-wide is doing, and that's been a great part of the richness that we've enjoyed sharing with you over these past months and years.
Absolutely, and I just want to point out that Dr. Chow will also speak to privacy-preserving record linkage as well. There was a workshop that both Patty and I co-hosted last week, July 29th and 30th, I believe, on privacy-preserving record linkage and the work that we are doing at NIH as a pilot. So that workshop will be, the part that was open will be made available through a recording fairly soon, as well as a executive summary that will provide some reference as well. And then I also look forward to Dr. Chow's talk in a little bit. Another question is, informed consent for later reuse is extremely difficult. How are you focusing on centering patient autonomy and allow them to opt out?
So it's a challenge that persists between the desire to have maximum flexibility in use of data versus respecting autonomy. And so many of our studies do allow specific opt-outs. We mentioned some of those examples around use for only not-profits or specifically not for for-profit companies. We have cases in which people feel strongly they want to provide the data, but only for discrete research areas. And although they're complexities for us, they are every much a part of what we have to respect in terms of individual abilities to constrain their consents. What's better now than it was, of course, is that we can do and design this prospectively. So we can, within our data sets, quickly search, scan, and allow only those for a given purpose, response to a given request that are allowable. When this can be done electronically because it's been designed prospectively, it's far less of a problem than it was when literally we had to go through consent by consent not so many years ago. So maximal respect. While we encourage and appreciate breadth, we respect the ability of individuals to modify. And I think with our current informatics and our databases, we can respect that without undue burden at all.
Thank you. Another question, do requirements to collect and save PII for linkages act as deterrents for participants from underserved communities?
That's a great question. As many of you may be aware, we're seeing that now, perhaps most prominently, or very prominently at least, in some of the COVID-19 related so-called RADx initiatives, which were designed very specifically to bring to, in particular, underserved, unrepresented, and vulnerable populations for COVID-19 testing to understand how testing could be best used, how it could be used to serve those populations, and in doing so, and in trying to maintain common data elements so we can pool into common hubs data for the power of cross-analyzing, we are addressing these very sensitivities. Our sense has been, and I think that Susan, Patty, many of you can speak to this too, because you know you've been a part of this, we're trying to distinguish the collection of sensitive data from the privacy in sharing those data. And at times that has been a workable distinction. So I think individuals are perhaps comfortable in sharing sensitive data, sensitive to them, in circumstances where we can provide assurances that they were protected against sharing beyond their consent. An important distinction, data collection and data sharing. The balance, of course, is that if what are sensitive information components to some individuals are not consented at all and can't be used, they to greater or sometimes lesser degrees compromise the utility of the very studies for which these participants are so generously volunteering their time and effort.
Absolutely. And I will note that in the privacy preserving record linkage work that we are piloting at NIH through RADx and through our recovery program, we do not store any PII. All of the data is encrypted and sent to an honest third-party broker. So we are taking particular care of in that respect. There's a related question. Given the significant distrust of research in certain underrepresented minority communities, how will mandates for broad data sharing be inclusive of these communities?
Yeah, an important question, but clearly something that disturbs us all, and we have to address these issues of distrust that have to do with providing data to anyone, perhaps ironically to federal or other organizations that are really designed and motivated for the health and well-being of populations who knowingly or not sometimes are sharing very personal data for other purposes they may not even be aware of. But yes, and so an education and information process, outreach with communities. A lot of our research now is being done through entities that have close relationships with communities themselves. And those are the relationships that build trust. I think that's going to be a core issue. We should note perhaps the most unique case we're facing is that around tribal sovereignties and the sensitivities of Native American, American Indian populations. And there we'll go to the extent currently being planned of establishing a separate and distinct data hub for collection and management of those data with strong participation of the research communities themselves. So community participation in all of these activities, strong and enduring and trustful relationships with these communities has to be at the heart of these efforts.
Completely agree. Another question. Are we moving closer to a point where it is foreseeable that a perspective could emerge that health data is a public need and a commercial need for entities in the marketplace of products that overrides individual rights? In other words, is the ethics of consent being slowly eroded in the modern era? So do the benefits of the health data for public need outweigh the ethical consent?
Well, Susan, Patty, I invite all of you too, but my sense is that we have not yet conceded that we need to erode the issues of public trust and privacy, and rather by allowing increased trust from communities to voluntarily share, so far, I think shows every promise of working. If we're talking about making mandatory the sharing of health records, I think that could be devastating and undermine the confidence people have in their healthcare systems, and counterproductively might lead them to separate themselves from the very healthcare systems that they need to preserve their own health and well-being.
Absolutely. The final question in our panel today: in moving data to the cloud, does NIH cover the computing costs for the research community, or is there a mechanism in place for researchers to pay for their computing costs? That may be more of a question for me in strides, but I'm happy to have you take the first answer.
Well, yes, you can certainly speak to strides. In other areas, yes, for some of our large programs and projects, we are taking on the expense of providing the cloud space. Strides, as you'll hear if you haven't heard already from Susan, is an NIH-wide effort that we participate in that helps make more cost-effective or efficient this affordability. And then, as I mentioned, there are other partners out there, such as Gates Ventures, and not the only one, but are looking through philanthropies and other models to make available large capacity cloud space. It's a challenge now, and it's only going to increase at a huge pace and slope.
Absolutely, and if I just may make a short plug for Strides. Strides is the science and technology research infrastructure for discovery, experimentation, and sustainability. It's our partnership with AWS and Google Cloud, and potentially other commercial providers for cloud services. Strides offers state-of-the-art data storage and computing capabilities. We also offer training and education for researchers and for students, and innovative technologies such as partnering with AWS and Google for artificial intelligence and basically code enhancement. Thus far, we have 58 extramural institutions participating with us in Strides, and Strides is through your university or your institution. Through Strides, we've stored over 115 petabytes of data between AWS and Google. And we've allocated 77 million compute hours. So I can put the link to the Strides program in the chat in a moment. I hope that you will explore it. Through Strides, you have the mechanism to provide for your own cloud compute cost. Some NIH ICs do offer cloud credits for very particular programs, but generally the researcher does pay for their cloud compute through Strides. So next question, can you describe in further detail your envisioned process for the ephemeral and analytics workspace? As you mentioned, these workspaces that aggregate data for a research task or a persona, but they expire. So this is a unified federated analytic data image. Once the researcher or the analytic task is complete, then the workspace goes away. Have you implemented this before? And if so, what worked and what challenges remained?
Yes, as noted, we have implemented it. It has worked. The challenge inherent, of course, is just as said, the fact that the data are ephemeral, they disappear, means that every time another analysis is proposed, we have to reconvene this mechanism in the space. But so far, that has been the central compromise when we don't have consistent and compatible consents that allow us to merge. I think that though it's been a very, very efficient and useful interim solution, I think and I hope that it will eventually be replaced by sufficient commonality in data use agreements and IRB perspectives so that we can actually have a longer lasting residence of data in a place where computation can occur while continuing, of course, to respect issues of confidentiality and individual privacies.
Thank you. This may be another question for me, but if you have your contract for your own cloud service, is that cost allowable under NIH grants as part of the project budget? So would you like me to tackle the cloud cost, or would you like to address it for NIA?
No, Susan, if you want to give a more general answer, that'd be great.
Yeah, so it is an allowable cost. It's under your direct cost. It does currently, we do have subject F&A to that cost, and typically people put it in the grant under direct costs under computer services, which does allow for the cost of the cloud for your research. A good one here. How do you support reproducibility goals for research if data need to be deleted after an analysis project? Okay, so this is for the ephemeral workbench.
Yes, I think, it's the same answer. This is the limitation. So if one wanted to, for an analysis that required data merged from two not completely shareable sources, and wanted to see if the outcome of that analysis was reproducible, in principle it is, because the contributing data can be reassembled, but it remains cumbersome and more expensive than would be the case if the reanalysis could be done on a standing existing non-ephemeral database. It's the compromise. Again, as I've said, I think it works and it's been extremely valuable, but clearly more cumbersome until we reach the time. And I don't know this anytime soon we're going to have all of the kinds of data that one might want to assemble for co-analysis and co-computation in one place.
I will note that we are taking lessons learned from the work that NIA has done in their ephemeral workbench to apply that to our work in recovery as we stand up our data strategy for recovery. We have currently funded our data resource core, and we have a notice of intent to publish a number of data repositories, all of which will work together to create that workbench for researchers interested in post-acute sequelae of COVID.
Yeah, it's a great case, Susan. You alluded to that in explaining what recovery was and kind of research, but it's being carried out by assembling to a large degree pre-existing cohorts and populations, and so it confronts just the patients that we've talked about.
At the moment, there are no further open questions. I'll give everybody a minute or so.
So I have a question while people are thinking. And to my colleague, Richard, first of all, thank you very much. The perspective of an IC director, which sets the tone for the unit, is really critical as we begin to this more data-driven research strategy. I wonder if you think you are ahead of the pack, or are you running alongside our colleagues, or I can tell you right now, you're not lagging behind, because your cogent conversation today shows that you've done a lot of thinking about this. But can we expect this across all of NIH eventually?
Oh, eventually, yes, and how soon we'll see. But to credit the work that this group is doing with you, Susan, Patty, you and colleagues leading it, has been enormously important. It's been so helpful for us to get where we have been, to be able to contribute to these conversations, have other institutes and centers do the same. It's one of the great strengths of NIH when we come together, and we certainly have on this one.
Thank you. Question here. Have you run into any challenges with consent for patients under the age of 18 whose parents may have consented to the use of the data on their behalf? And how do you manage those consents once the research participant is older than 18? Actually, that's a great question. Thank you, Hannah.
You know, it's a great question, probably more frequently addressed by institutes other than the National Institute on Aging. But we do have studies that depend upon surveys that were initiated, for example, by National Institute for the Child Health Institute, where consents were by parents and who then aged in. And when we go back, ideally, in cases where informed consent for individual data is needed, we need to go back in and reconsent.
Thank you. Okay, so I think this may be close to our last question. At our institution, multiple researchers will go through the process of requesting data sets from external providers such as Medicare, the state, et cetera, in order to power their studies. This can be cumbersome and take months per researcher with lots and lots of duplicative work to gain access to the same resource. So what we'd like to know is, how can you recommend streamlining institutional access to heterogeneous external controlled access data sets that might be coming from multiple providers with differing applications and differing usage requirements? Complex problem.
Yeah, so in particular around, for example, Medicare and Medicaid data, that's been something that we've been dealing with actively for a good number of years, and for contacting to the relevant NIH staff who've played a leading role, I'd be happy to establish those contacts. But we've looked into and are continuing to look into more and more inclusive ways in which we at NIA and NIH can contract with CMS in such a way that data will be accessible in response to multiple projects, streamlining the access, making far less costly the current pricing system in which each individual investigator or initiative has to negotiate for recovery or specific data. We've used one of the early users initiating the enclave concept, so that, again, data can be carried out in an enclave, secure enclave of CMS. Data from other sources brought in, always with careful scrutiny by both of our agencies for propriety. But yeah, be happy to establish contact with you for what's going on, has gone on, and is in the future at NIH, because this has been very important to us, particularly on Medicare, Medicaid, but not isolated to it. We're trying to make it a more NIH-wide corporate approach to data access.
Thank you. This will be our last question to keep on time, but it's a good one. Would you like to speak a little bit about the Gates venture and probably the 80 workbench?
I think what I can best do is and maybe the question already has the links, but we have shared common interests. So around Gates ventures, among others, is this initiative ADDI, as we talked about, is the Alzheimer's disease initiative in particular, one component of which is establishing this workspace. We are working closely with them, we being NIA, through our own SAGE portal. We have a workspace that we have created for multidisciplinary work. I should note that the same portal is now going to be used beyond NIA and Alzheimer's research, be a common portal for one of the other AMPs that's been looking at autoimmune diseases and inflammation. So we're trying to maximize the way in which a given portal that we at NIH support has access to multiple kinds of data. But we have, last week was the most recent conversation, frequent conversations with ADDI, trying to work together so we can make most efficient the choice of shared resources, and what we learn in providing space, but in coming up with the computational tools that are necessary in the workbench. So ADDI have been a great, Gates Ventures have not been the only partner, but they've been a great one, and we're open to negotiating with all who have common interests and can learn from one another.
Thank you so much, Dr. Hodes, for your stimulating presentation, and to everyone for your questions. It's really, really interesting discussion today. I'd like to begin our panel with 3 speakers. As a note, we will take Q&A at the end of each presentation, and then we hope to have a little bit of time left over for some final questions for everybody. I'd like to introduce our first speaker, Dr. Ana Narvaez-Achian. Dr. Narvaez-Achian is a physician epidemiologist with a specialty in preventative medicine and public health, and holds a PhD in epidemiology. Her research team investigates the long-term health effects of environmental exposures, arsenic, other metals, tobacco, air pollution, for example, and their interactions with the genetics and epigenetic variants, and the effective interventions for reducing involuntary exposures. She collaborates with major cohort studies, such as the Strong Heart Study, a study of cardiovascular disease and its risk factors for American Indian communities, and the multi-ethnic study of atherosclerosis, a study of cardiovascular, metabolic, and lung disease in urban settings across the U.S. Both in the U.S. and internationally, Dr. Narvaez-Achian evaluates exposures to tobacco smoke, including emerging public health challenges such as water pipe smoke and e-cigarettes. Her goals are to contribute to the reduction of environmental health disparities in underserved and disproportionately exposed populations. Thank you so much, Dr. Narvaez-Achian, for joining us today, and I really look forward to your talk.
Thank you, Susan, so much for the introduction, and thank you to the NIH Office of Data Science Strategy for this opportunity. I hope everybody can hear me well, and I am going to share my screen. And what I wanted to do today as part of this presentation is to focus on my experience working with indigenous communities, how they perceive the issues of data collection, data sharing, science in general, and how to move science forward given their perspectives and their very important input. The work that I've conducted with indigenous communities is related mostly to environmental issues, environmental problems. This is important for them as there is strong evidence that tribal communities, indigenous communities in the United States are disproportionately exposed to environmental agents, including, for instance, metals, because of the past practice of and the numerous amounts of abandoned mines in the Southwest, and also in the plains, also in the Great Plains, and in other parts of the country also. So for that reason, exposure to uranium, for instance, but many other metals that come together with the uranium is a major concern. And as part of the Strong Heart Study, which is one of the cohorts that I work very closely, we found that both arsenic, tungsten, and uranium were clustering together and disproportionately higher compared to MESA, which is a study in urban cities across the US. So this collaboration across these 2 cohorts that was possible through this partnership that we have with the Strong Heart Study. So the Strongheart study is the largest and longest study with American Indian communities, ongoing since the 1988, funded primarily by NHLBI, although since 2012, some important funding has come from the NIH. There are more than 7,600 adults, and 13 tribes and communities are part of the study. As related to issues related to consent to be in the study, not only the individual has to consent, but the community has also to consent. And tribal consent to participation is really important. And one of the tribes, for instance, like 5-6 years ago, decided they no longer wanted to be followed and to be part of the study. They agreed to keep the data, so all the past data that had been collected could be stored, but they indicated that they no longer want that we use their data for research. And as scientists, we had to respect that wish. So nowadays, the Strongheart study has participants from 12 tribes. The tribes are, and the communities, the participants are in Arizona in the Southwest, in North and South Dakota, in the Northern Plains, and in Oklahoma. These communities are very different. They have different traditions, different cultures, geographically are very different. Some in the Dakotas are very rural, very spread. In Arizona, they are close to Phoenix. They've seen wealth, more relatively economic development in recent years. In Oklahoma, they are in urban areas, but they still keep their very strong traditions and culture. This research is only possible through team science and participatory approaches. And we meet regularly every year in each of the communities to keep that conversation, to keep the input. And actually the research is possible because there are community members who are involved in the research locally on site. And this is the reason why this can happen. So this is in Eagle Butte, South Dakota, one of the annual meetings. And some of this is actually the office for the study in the Dakotas. Today, we continue now meeting virtually through the pandemic. And actually, it has been a positive experience to be able to interact more across communities. In the past, the meetings were more centralized in each community. And now today, with the virtual world, the communities have really come across working together, which has been a very positive experience. But I am not an indigenous scientist, and I've had to learn a lot to be able to do this work together with the tribal communities. And I want to bring here some important concepts that Spiro Manson, who is probably one of the top Native American scientists in the US, has really shared in several occasions. And this concept is related to collective competence and how in tribal indigenous communities, authorities really root in this idea of collective leadership. And decision-making is horizontal, based on what has happened in the past, and consensual, what requires a lot of effort and debate. At the same time, once consensus is reached, this means that has potential a big impact and a very positive impact. Also leadership is shared, and not necessarily the leader is, the theoretical leader is the only leader. There might be leaders in the community that can be very regarded and very important to incorporate and to respect and celebrate that tribal communities are sociocentric and have a lot of input to our mainstream society. So the way we've incorporated these principles in my own personal work, for instance, is the value of traditional knowledge. We do a lot of research on water and water quality. So we acknowledge that water is life, which is an extremely important concept for tribal communities. And also the idea of the 7th generation principle, which is also very important for the research that we do in terms of epigenomics, transgenerational effects, the idea that what we do towards our population, our people, our system, our world today is going to have consequences down the road, in generations down the road. The third concept is the idea of relationality, which I believe it's also very useful in our system science, all the work that we do now with omics, metabolomics. We tend to think in science in a very linear process. However, there are so many complexities and feedback loops that things are really connected in more a circular manner rather than in a linear way. So those principles are actually quite helpful for us to think and incorporate into our science. Collective leadership, this is not the scientist alone in decision-making. The community input and the decision-making needs to be shared, genuinely and transparently shared. And then we have to accept the research codes that the tribes have developed to regulate the collection and circulation of information about their members. This includes the concepts which are essential of sovereignty and data ownership. And I want to come back to this concept that scientists or governments don't necessarily own the data that has been collected, but that the communities are the true owners of those data. And so we need to develop systems in place that reflect and respect that ownership. The tribes and the Indian Health Service have developed their own IRBs. They often are called research, they are not called institutional research boards, they're called research boards. And this is very interesting concept because they don't only review the protocols at the beginning, which is the traditional IRBs do. They review the consent form, they review the protocol, and then the scientists do their work and they publish their papers, but they don't go back with the final product. In the tribals IRBs, in the Indian Health Service IRBs, the final product is reviewed before it's submitted for publication. And this is a big difference that I perceive as compared to the traditional way in which we do science. And they also review the publications and the lay summaries. So we need to provide the lay summary before they are being submitted for a publication or for any formal dissemination, maybe through a presentation in a seminar like today. For that reason, I am only going to present today things that have been already reviewed and approved by the tribal communities. And so in the work that we've done, we focus on environmental issue problems, and we often use biomarkers, in this case, metals, because we do, as you saw, there is a big interest in uranium, arsenic, and other metals. And we look at the impact these metals have on clinical disease, and we look at many susceptibility factors regarding genetics, nutrition, and we are very interested in mechanisms. And this is possible because of this long-term sustainability and support for science. Going on since the late 80s. And this is basically, there was an original cohort through the late 90s, and then in the early 2000s, there was a family component, which builds the main study today. There have been some gaps in funding, and that's why the years and the visits are not equally distributed. But overall, this is an important thing for tribal communities. In general, they don't like helicopter science, the idea that we would come to do a study and then we leave. They value and appreciate these long-term commitments with science. If we are there and we continue with their support, science can be extremely successful, and it can help us answer things that we have never thought about. For instance, when the study started, they were not really concerned about environmental exposures. But then we went back many years later and we were able to measure metals in the urine, in particular arsenic, which we could see from the pilot study that we did that was high in Arizona and also relatively high in the Dakotas, although there was more variability. So the data were extremely helpful to answer an important question for the United States and of course for their communities, the tribal communities, related to the health effects of arsenic. And we found that arsenic was exposed, are related to higher risk of cardiovascular disease. We've done a lot of research on the health effects of arsenic and other environmental exposures. For instance, we did also work on arsenic and cancer. with Dorothy Rhodes, who is a physician and tribal member in the Oklahoma. She's at the University of Oklahoma. And we found an increased risk with multiple cancers. But why I'm bringing this study here today is because cancer was not part of the original consent. And the tribes was not specifically in the tribal consent, the informed consent. The consent was very broad. Scientists, we thought cancer was included, but the communities didn't have that perception. And so we had to really talk to them and have the real thorough discussion to make sure that this was okay to do. Because initially they were shocked that we were doing cancer research. They thought the Strong Heart study was only about cardiovascular disease. So I think this is very important to keep those lines of communications always open with your original participants, with our original communities, to ensure that there are no surprises in the work that we are doing. And one of the work that we are now advancing is through related possible mechanisms and going into very quite sophisticated cutting edge research. Sometimes people have the misconception that because you do participatory research, because you spend a lot of time with the community, talking with communities, doing your work, that that's going to be second-class science, that we cannot do the top level, high cutting edge level science. And I want to say today that's not true. Communities are very smart. They can understand very complex concepts, and they are interested in understanding why things happen and what can be done. So they are actually very interested in learning about those mechanisms. So we've worked and done epigenomic work, and we showed, again, going back to these DNA samples collected in the late 80s, we were able to show that this is very robust, high quality data. And we were able to communicate to the communities why this is important to do. And we spent quite a bit of time doing that, but the studies were approved with a lot of interest, I would say, from the communities. So I don't really want to go too much into this, but we have a number of studies that have been published. We have a number of studies that are ongoing, really focusing on DNA methylation, epigenomics, looking into the effects of environmental exposures, looking at the multiple health effects. How can epigenomics help us with maybe the diagnosis and early identification of some lymphatic and hematopoietic cancers, for which we have the target tissue in blood. So all of this work is ongoing, always making sure that everything is approved by the communities before submitting for publication. And we've even participated in numerous consortium and projects. For instance, I have this recent project here with multiple studies from the UK and many other countries showing some commonalities and differences in DNA methylation signatures with tobacco. And we also do work in genetics. Again, there is the misconception that you cannot do research, genetics research with indigenous communities. And that is not true. Again, you need to be very transparent, and the communities need to approve and need to value the research that we are doing together. So I am not really going again to show the results that we've done, but we found some very important genetic signals for the way how arsenic is methylated in the body, with important implications for the health effects of arsenic, showing how environment and genetics need to be done together with community participation and approval. And as we move into more complex omics research, incorporating multiple layers of complexity from genetics, methylation, protein expression, metabolomes, and this is going to require even more close work with our tribal communities to ensure that they value the science, they understand the science, and they want and are interested in being engaged in this science. This work is possible through the very strong work from the Strong Heart study. And this is the website where all the information is very easily found about all the data that is available. with really high level of detail and information, and especially all the information in how to get approval. Anybody is invited to participate, but we need to follow the rules that the tribes have set in place. I was myself an external investigator. I was not part of the original Stronghold study. I had an idea, I proposed it, and the tribes agreed that this was a research that was worth pursuing. So I would like to invite anybody to check the Stronghold study and really understand the process, and that it's really possible to do a high level, highly collaborative research with tribal communities. However, it's important to think who owns the data, and questions that are really critical to understand the perspectives from the tribal communities, the issue of ownership and who allows data sharing and in which terms. Very naively myself, when I was a more junior scientist, I had the sense that I was the owner of the data because I had this idea, we put the study together, or maybe our team, our research team, maybe our institutions who were helping us and facilitating all the research and supporting all the work being done, maybe the NIH, but the tribal communities have said that they own the data. And this is because they faced substantial harm in the past. For instance, genetic data that is collected for one purpose and then used for something else, that the communities are then surprised and shocked. And so that's not acceptable. The tribes, the communities need to be informed, and they need to agree to all the research questions used with this data. And I would argue that this is true not only for tribal communities, this should be true for any community. People should know, should be aware how their data is being used for. And for instance, this other example where through the presentations of the data and the publicity through a New York Times article, the community had a negative economic impact that was very serious. So all are just two examples of many more that shows why tribal communities are so concerned, and they are resisting unrestricted data sharing. They don't want to do it in a way where they don't have continuous control, and especially the decision-making, being able to say no if they are not interested in a particular question. So I would say, I think many of you might be familiar with this picture related to how tribal communities in the Dakotas were resisting the Dakota Access Pipeline a couple of years ago. So the same way that the communities are protecting our environment, they're also making us think hard how to protect our data and make sure we are doing data sharing in ways that benefit communities and the people who provided the data in the first place. So thinking of who profits from research is extremely important. I've obviously benefited from that research. I got promoted, my career is going well, I have a good job that I enjoy. But who else is profiting from this work? How are the original communities who provided this data are really benefiting and having, and that's the only way they are going to continue to value science. So there was this paper just published in Nature. It's this a letter published by indigenous scientists a few months ago. And they wanted to remind us, all the broader scientific community, that having many broken promises on how the medical knowledge in general benefits the communities that provided the data in the first place. And there are still so many inequities that we need to make sure that we address. Otherwise, this is not going to be a positive outcome in the end. And I'd really like to think what they say at the end, that the data that we have it on loan. We need to show that we are responsible. We need to show that we know and respect the communities and participants who gave it in the first place. And there is more and more this concept that indigenous people must benefit from science. It's growing and acknowledged, and I am happy to be here today in this session, being able to share these ideas with all of you. So always in my science and the work that we do as a team, I always think, how is our data relevant? Of course, there is a lot of implications on my environmental work that we do with arsenic and many other environmental exposures that helps the EPA, many other global organizations. There are regional impacts with how we decide on resources, prevention strategies. But again, we need to think of how to intervene and use it for prevention locally in these original local communities. So for instance, I am very proud and happy to say that there have been big investments for water quality in some of the tribal areas in the Dakotas. And we continue to monitor and evaluate those new water systems. And also we are doing additional interventions for the families and who are more remote and have difficulty to access community water systems, so that those people using private wells can also benefit. So we are doing some work with, especially I want to highlight Marcia O'Leary, who is the director of Missouri Break. She's a community member. This research company, Missouri Breaks, is 75% indigenous people working in that company. They are local, people trust them, and it's an honor, a privilege to be able to work with them to make sure our science is translated and has a local impact. And these are some of the meetings that we've put together and that we meet very, very regularly, very often to ensure the science is done well. I want to highlight, for instance, Red Cloud, who is one of the director of the natural resources in the tribe in South Dakota. So communities and participants make research possible. As scientists, we need to ensure their engagement and participation, their support for science, their contributions, acknowledge their contributions to the research questions and their contribution to conduction of research. And we need to respect and acknowledge their decision-making ability regarding data access and data sharing. And only if research benefits communities and there is real trust in how this process is happening, the communities and participants will continue and remain engaged. But we need to, of course, indicate that the benefits are slow, but I believe we need to have that active engagement. So I am going to finish now the funding from multiple sources. I want to acknowledge NHLBI and NIHS and the Superfund Research Program. And NIHS has multiple initiatives for data analysis and data sharing that have been extremely helpful, including the HERE resource to do environmental assessment that I encourage many of you doing work to inquire about research, inquire about this option, because it's an incredible resource for environmental assessment. And then also Michelle Hickok, who is the big health science administrator at NIHS, focusing on this issue of fair and trust principles for data sharing. And of course, I need to acknowledge the students and trainees who are ultimately the ones moving the science forward, many of them who are, several of them who are indigenous scientists. So thank you very much, and I'm happy to take questions.
Thank you so much. I want to echo some of the comments in the chat. This is an excellent talk. We really appreciate this perspective, and we do have a number of questions. The first one, does tribal data get merged into larger databases? And if so, I don't know if you can speak to it or not, but what precautions are in place if researchers are able to download and use that data? Would you like to address that?
Yes, absolutely. And that's extremely important. I should have mentioned that a little bit more. So the way it happens, you are an investigator, propose a research question, it gets reviewed. It might be in collaboration with a pool cohort, with another cohorts. So it gets reviewed by the publications committee, which includes tribal members. And if the project is approved, and I have to say, most of the projects are approved. Occasionally, if there are questions that are highly sensitive or for some reason not acceptable, but not even 0.5%. In my experience, that almost never happens. So if you have good science that you propose, your project is going to be approved. And then once approval is obtained, there needs to be a data agreement that has to be signed, indicating that you are going to only use the data for that particular project, for that particular question that has been approved. And then the data is transferred if it cannot be analyzed remotely. For instance, all the genetic data, all the epigenomic data, all the omic data, we have it in the servers that are in right now at the Texas Biomedical Research Institute, and the data are analyzed on the server, so they are not downloaded. But for all the other data that we have, often they are transferred, but with the agreement that that investigator is only going to use it for that question. And then before publication, as I mentioned, you have to submit your paper before, and you need to get tribal approval so that you can publish your paper.
Thank you so much. A good question, and I wonder if you'd like to address it. Certainly we can as well, is are we interested and are you interested in the CARE principles? Just quickly, CARE is like FAIR, but for Indigenous and tribal data, perhaps for all data, collect for the benefit, C, authority to control A, responsibility R, and ethics E. Would you like to comment on the CARE principles, Anna?
Yes, I mean, that seems to be very much in line of what I've been discussing, and that's really, really important and critical to follow those principles. So yes, I would say thank you. But ultimately, the big issue is acknowledging the data sovereignty. I think that the sovereignty and the data sharing restrictions is ultimately, I would say, the most important element in this issue with working with Indigenous data.
Thank you.
I'm happy to hear your perspective too, if you would like to add something.
Absolutely, I think that's a really important point, to not only be fair, but also to care. And so I really want to thank you so much for bringing that up for discussion and for awareness for the larger community. So I hope that you'll see a little bit more about CARE in the future as we move forward with tribal and Indigenous data. A good question here, in terms of data ownership and Indigenous knowledge, how do we deal with the rights? Should there not be a rights agreement? And also, communities are often split when actual money is involved. Would you like to address data ownership and data rights?
Yes, so that's why we rely heavily on the research boards that the tribes have, and the boards have to agree on the research. And often there can be some level of discussion. Often you need to come back at several points, and there might be no total agreement within the tribal community. But at the end, in my experience, what they provide, they could maybe deny some research. I've never faced that situation personally, but what I've faced is actually it's not true. I am going to give an example right now.
Uh-oh. Uh-oh.
It appears that our speaker has frozen.
Oh, I thought it was me. I am so very sorry, Anna, you have frozen. The joys of remote workshops and conferences. All right. I am so very sorry. We could give her a moment.
If you want to proceed, I'll make sure we have time at the end for Anna to finish her remarks.
That would be wonderful. Yes, I think that in the interest of time, we will have to proceed, but we will come back to Dr. Navarez-Achian at the end of our next two speakers. And I do want to thank her for her really wonderful talk, and I'm really looking forward to a panel discussion. But I'd like to introduce Dr. Lucia Ona Machado. Dr. Ona Machado received her medical degree from the University of Sao Paulo and her doctoral degree in medical information sciences and computer science from Stanford. She is the Associate Dean for Informatics and Technology and the founding chair of the UCSD Health Department of Biomedical Informatics, where she leads a group of faculty with diverse backgrounds in medicine, nursing, informatics, and computer science. Sounds really wonderful. She serves as editor-in-chief for the Journal of the American Medical Informatics Association from 2011 to 2018. Dr. Ona Machado directs the Patient-Centered Scalable National Network for Effectiveness Research. It's a large clinical data research network covering more than 30 million patients and 12 healthcare systems. And she is one of the founders of the UC Research Exchange Program, a clinical data research network that connects data warehouses of the 5 universities of the California medical centers. She was the director of the NIH-funded National Center for Biomedical Computing, the IDASH Center, which was based in UCSD with collaborations in multiple institutions. And she has a number of other NIH-funded consortium and research projects, including the RADx-RAD Data Coordinating Center. Her research focus is on privacy-preserving distributed analytics for healthcare and biomedical research. Thank you so much, Dr. Ona Machado, for joining us today. Really looking forward to your talk.
I'll try to speak louder here. Can you hear me?
Yes, we can hear you fine now, Lucila. Thank you.
Okay, great. Thank you for the invite. So I'll talk about making control data access readily findable and accessible. As we know, we all need large amounts of data, particularly now with deep learning models and artificial intelligence, to do a variety of models, predictive models and analytics. I list here some of the examples. And as you can see, lately, COVID-19 prognosis and dealing with sequelae are also a very important topic. Let's say some user wants to find all data about type 1 diabetes and HLA mutations, medical records, images, and genomic data. Years ago, we created a data discovery index called DataMed, in which data from multiple repositories were harmonized, metadata were harmonized in order to make discovery possible. And this included millions of data sets. And again, it was several years ago as part of the BD2K Big Data to Knowledge program. The search engine would accept free text, and you would get in return ranked data sets. Many at the time said, well, you shouldn't do this because soon enough Google will have its own data search engine and this will be obsolete. 4 years later, Google has not done that, and the need for a data discovery index still exists. More recently, we have also done a specialized data index for COVID-19 data sets, and this is Dr. Xu from University of Texas has put his team to adapt DataMed into this COVID-19 data index. And the need for such search engines still exists. What is involved? Well, first, metadata needs to be harmonized, and it needs to be represented in a common format. Various representations exist, and I'll focus this talk more on technical challenges to represent participant consent. Which data are shared, who are the data recipients, what data recipients can do with the data, way in which data are collected, curated, stored, distributed, and destroyed. These are all items that if we want to streamline access and make this more automated, will need to be discussed. Also process challenges, detection and consequences of data mishandling, data collectors' incentive to use data standards. We're all part of an ecosystem of data that needs to consider everything, not only how to index those data. And as part of the BD2K program, we have produced several articles related to DataMed, the discovery index, as well as the data representation and metadata harmonization. I want to draw attention to the latest one, which was related to discovering data access and use requirements. so needed for automating and streamlining access. I must say we're not alone. The GDPR, the General Data Protection Rule in the European Union, has been dealing with these issues in order to say what's the name of the company or organization processing your data, purposes, categories of data, length of time that the data will be stored, other companies and organizations that will receive your data, transferred outside the EU or not, basic rights, and so on. So all of this requires a lot of thought in how to organize the information. And I would invite you to see more details in this GigaScience article, in which we outline data use agreements, primary use for research, secondary use of research, what's involved, legal aspects, as well as other technical aspects on how to do the metadata representation. Also, how to reuse and what has already been developed, for example, by the data use ontology or informed consent ontology, so that we don't have to reinvent most of it, and just make sure there is an automated way to check for consents, which as previous speakers have mentioned, vary quite a bit across cohort studies and across other studies already done, and also will continue to vary prospectively. So I want to draw attention to two types of data, one which I will call partially consented data, and then the consented data. I call it partially data from electronic health records, because when patients go for care, they do sign a consent for care, which most of the times includes use for research. It's not very explicit what it will be and so on, and it will certainly done within legal limits, but no extra consent is needed in the US if the so-called de-identified data are used. And then consented data from studies, again, it's been said before that it comes in many flavors. However, I would say mainly de-identified data and consented data, they can all be re-identified. And the next speaker will talk about issues like that, but I'll say the success from re-identification depends only on what the data, where they go to whom they are disclosed, and who the attackers are interested in identifying, how much time and compute they can afford for that particular process. So I wanted to make it clear that for HIPAA so-called de-identification, there are two methods: expert determination and safe harbor. And safe harbor, it's usually the removal of 18 identifiers such as dates of service, biometrics, names, social security numbers, etc. And then expert determination is very rarely used, so I will not go into those details. That are also so-called limited data sets that have de-identified data plus dates, and these are usually transacted through data use agreements of institutions. Now, I just wanted to briefly go over what is it that we are so afraid of re-identification. How can it be done on so-called de-identified database? I think that the best way to say this is people think that from data from this square here, you might be able to recognize, oh, this is Lisa, this is Mike, this is Alice, etc. And in this case, yes, because if you have a biomarker, a biometric for Lisa, let's say a fingerprint, and you check that fingerprint against a publicly available database, such as this one here, you would clearly know that, oh, this has to be Lisa, she is pregnant, and her income is 60K. So for these reasons, biometrics are not allowed in de-identified data sets, but there are other items. For example, let's say variable A and B, you happen to know that Lisa is A equals 10 and B equals 20. So you can do the same process, read out whoever has those characteristics and understand that Lisa is pregnant and her income is 60K. Now, What are these combinations? Well, there are many, including, SNPs or variants in the genome that you could just re-identify people this way, or could be other characteristics that So these are not identifiers. This would be a de-identified data set, but still, if you have enough information of the person who you're interested in, you can read out the details. And also, it doesn't need to be a unique entry for A equals 10 and B equals 20. In case there are two entries, but they both point to the item you wanted to know, which is that diagnosis, and they are the same, you still disclose information that you would otherwise not think you are disclosing. So there are several techniques that have been proposed. K-anonymity refers to the uniqueness of data sets, and then L-diversity goes beyond that to address this other problems that I'm illustrating here. But there are many techniques, and I will not talk about that because that's the subject of our next speaker. But I'll talk a little bit about the overall landscape in which we are trying to share data. So again, genomes are biometrics. I want to make this very clear. They're the best ones, and therefore they should be treated as HIPAA identifiers. Sensor data as well, images and so on. So then you do use Google to say, well, re-identification using wearables, how many results do you have? And there are so many papers describing this, as well as for images and so on. So it's a real issue. Re-identification of a target individual is a real issue, and therefore the data sets need, for the most part, to be under access control. And then how they are distributed is another issue. Genomes are excellent also for the attacker because you don't even need to have the exact match of the individual. You have blood relatives that could have that information that can be used. For example, was used for getting the Golden State Killer in this very publicized use of ancestry data for this purpose. So in a way, not only the entries in the database could lead to breach of privacy, but even the name of the database. If you have a public de-identified database of a certain condition that can be considered by some stigmatizing, just having a match of the person of interest into that database would review that condition. And of course, by linking other data from EHRs, personal monitors, other databases, or information you know about the person of interest, that could breach privacy, which is why it's important that we think very much about how to make this data available. Is it ethical to share? Many people have not been explicitly asked and don't know who is sharing what. Is it ethical not to share because new discoveries and acceleration of science depend on sharing? Could people choose? Is it practical? What if massive number of people withdraw their data? So these are other considerations. So privacy versus data sharing, there's much we need to think about. And personalized medicine depends on big data sharing. Getting enough data to study rare diseases is already an issue. So how can we deal with that? It is difficult to quantify privacy risk and the potential benefits because these benefits are all in the future. So streamlining access control sharing will mean quickly determining who will use the data and why, and provide this controlled access. Authenticate users and authorize users, main part of what we're discussing, but also monitoring this use is important. So it's a global process that we need to think about, not just the access. The data governance benefits must outweigh the risks. Having data sequestered in an enclave is one step towards preventing widespread distribution of data to potential attackers, but it's not sufficient since you can do that matching within the enclave and breach privacy in that way. The more databases are linked to other data, the higher the risk of privacy violations. researcher-based blanket authorizations such as passport models can increase disparities and do not provide comprehensive control. So that needs to be thought of very carefully as well. Controlling how data are used is one way of mitigating the risk. Access to data on a need-to-know basis should be exercised. We also proposed different ways of tracking and recording how these things are used on an immutable ledger. And the technical aspect of which database you use to do that is not important here, but more, we all can do authentication. There are multiple ways of doing that, but the authorization, according to those consents, is something that is much more complicated. Use logs, how to analyze them, how to ensure also that there is attribution of data to the originators, and how to do reproducibility or other topics. And then as I know Dr. Cho will talk about risk analysis, privacy breaches and techniques to deal with that. So I won't talk about this data-centric approach to protect privacy, but I'll talk about two ways. One is a people-centric, and the other one is institution-centric through data brokers. So the National Center for Biomedical Computing focused on data sharing and analysis was more than 10 years ago, when we were thinking about several of the issues that are coming up here. I will not comment on download models or even models that you compute in an enclave, but talk about one model that we thought for partially consented data was the best way to deal with it, in which we do distributed compute, in that institutes retain the data at their location and therefore respect the partial consent that patients have provided, and then participate in analysis that are for the greater good, for scientific interest, without releasing those data. And you can do several computations with that beyond, of course, counts. This is called distributed analytics, with each hospital, and in this case, maintaining their own data, but participating in computation. There's also vertical partitions in which, if the patient consents for linkage, the data could continue at another place, for example, wearable data at the one site, and medical center data another site, because neither party wants to give their data to the other one. So there are ways of doing that, and that's how we did with this clinical data research network in all the University of California, with the VA national system, with several institutions in LA, and increasingly in other institutions in Colorado, in more recently in the DC area, and Atlanta. How this works, we basically harmonize the data, we agree on rules of engagement, and we share ethics principles. More recently, we've done this for the COVID-19 clinical data consult. We call it the rapid response data discovery for COVID-19, and it was launched within a month. We could get these institutions together in order to share results on the data. This is a public website, covid19questions.org, in which anyone could ask a question. And then a group would decide, well, this question is answerable with electronic health records, and is a question worth answering for the public's benefit. And we have done that for several of such questions. The results come, for example, you might remember in the beginning of the pandemic, people were worried about patients taking ACE inhibitors. Was that a higher mortality or not? And we were able to, for hospitalized patients, compare that and produce and publicly display those results. Same thing for age, as we know that this picture has changed recently, but in the last year, this was the picture. And also we can do multivariate analysis. So you hear see a logistic regression done on several institutions, again, without moving the data anywhere, but bringing that computation to the data. And we did it rapidly because we were dealing with so-called de-identified data. Tables such as this one here were put aside on the environments of each one of the institutions outside the firewall, and accepting computation through the program that would be installed, run with this real de-identified data. And all that was exchanged was matrices like this that would not compromise any row of data. So decentralized access to data can be done with a lot of programs. So different programs can contribute to this decentralized access without having to move their data anywhere. And that's how we did this, and how we would propose to do with many other programs. So anyone could serve as a node, and anyone could serve as the initiator of this query or this analytics. So patient data stays at institutions, and code is made publicly available. And just to plug here, code discovery index is also needed. So that is about the data broker when the clinical data research networks decide. But we had this idea and been working on it for several years on how could be patients define those permissions. So informed consent for clinical data used in research is a project we started several years ago. And it came from the realization that different groups have different preferences for data sharing. We just heard from the Strong Heart group, who we also collaborate with this cohort study, as well as some others, the study on Latinos and study of Kawasaki disease, a rare disease, and also underserved populations, uninsured populations. And how can we make sure that we are attending to the preferences for data sharing for groups, or in our case, for individuals? So the current model, the healthcare institutions decide this is a worthwhile study, and provided data are de-identified and used according to the legal processes, the data user can perform the analysis. What if the patient decided that, and we define a public interface in which people can decide, do I want to disclose data to this particular user? Can I check which users touched on our data, on my own data, and so on? So we created an interface. Again, this was years ago, in terms of each item. Do I want to share with UCSD and the VA hospital locally? Do I want to share with nonprofit organizations or profit organizations? And then we wanted to study this data sharing choices. And for 2 years, this pilot ran at UCSD, and we honored those data sharing experiences. So we wanted to know about tissue samples as well as so-called sensitive data. And this ran on top of our clinical data warehouse, in which we would then establish this interfaces. And here, for short, is kind of the answer. And you can view it as a cup half full or half empty, depending how you're looking at. But for each item, on average, like 10% of the patients would not like to share that item with anyone. About 50% were fine sharing with any of those 3 categories. In this other color coded here, the purple is share only with UCSD, and the orange is share with any nonprofit institution plus UCSD. So as you can tell, we might be doing the right thing for a large number of people, but individually people would like to choose. Furthermore, they are more willing to, 35% are equally willing, 59 equally willing, and 35% more willing to share the data if they have that visibility. And if you know who is using, that was a big item, 73% are more comfortable if they know who is using that for what. They're equally for healthcare and for research, with some 7% not knowing, 9% more willing for research than for healthcare, and 5% the reverse. Interestingly, they wanted to know each time, 61% each time the data were used, they would like to be notified. We followed that with a relatively larger study. The same results apply. We had more items to look into, and just pay attention. Social economic status such as income was an item frequently denied, as well as sexual life, home address, phone number, and so on. So in short, data sharing for rare diseases, common and emergencies, there is a way to do an agile controlled data access. It is needed. Partially consented data such as EHRs, even if de-identified, pose significant ethical challenges if they are shared broadly. Consented data require data access to follow the process explained in the consent form. There's no way around that, and the consent forms should be as explicit and as specific as possible. So in conclusion, protecting the privacy of individuals is critical. Helping researchers find and access data is critical, and transparency in data use is also critical. We need consents that will not damage AI research, and in fact, they might facilitate it. From our data, 50% of the people probably want to share more than the organizations are currently doing. And we should promote AI fairness as well as AI fairness. And I would say the lowercase fairness might be as important or more than the capital fairness in here. So I wanted to end by thanking the funding sources and say asking people is a fair way to doing things. And again, NIH has been investing in research in this area in our group and others, and I just wanted to acknowledge here some of the sources. So thank you so much again for the invite.
Thank you so much, Dr. Ono Machado. This was a fantastic and very thought-provoking talk. I'm going to turn to some questions. A few of us are interested in the idea of, should rare disease populations be respected and approached by scientists as they are with tribal data and tribal sovereignty are respected and observed? Would you like to talk a little bit about rare disease populations?
Yes, and then I think that you know, having personal experience with some of that, I can say there is an eagerness to find cures, to find solutions. And if I would say there are families or individuals who were more than willing to share, and share way more than we're currently doing. And on the other hand, there are also others who, you know, are more cautious and want to wait until the value of such sharing is clear in order to do it. So I think it's very important, as other speakers have referred to before, as developing trust in returning value and seeing that there is value in doing all this.
Thank you. Sempa asks, most pharma companies want to democratize data access and data use, which would lead to an open by default approach. How would you reconcile this with the need to restrict access for data?
Well, as I mentioned before, I think the intentions are great. I'm not sure everyone fully understands the risks and what can be done if data are just out there and free to link with other information that you have about target individuals and about the damage that can potentially occur if these individuals are found in such databases. And, you know, it's upon your imagination to think about, it's not only VIPs, it's ex-partners, it's paternity checks. It's a lot of issues that can happen with normal I would say normal people, non-VIP people, that unfortunately people are not aware of this, and with all the good intentions want to share more, but don't realize the risks.
Thank you. This is a great question. Can you use your consolidated indices to detect data desert patterns? For example, populations or places where a particular data type would be consistently not collected, or where non-random or missing data patterns may emerge across the data set.
I think we could, and that would be a great use. Are we there yet? Probably not. You know, there's much more that needs to be done, because again, even with all the effort that we have done, we haven't indexed everything, right? We've done the major repositories and so on, but there are a lot of what I would call orphan data sets out there. They're not in repositories. They're available because they go together with a certain publication and so on, but it's very hard to index those. So you take that mass approach first, but you might be missing a lot of those other ones out there.
Thank you. This may be our last question in the interest of time, but would you elaborate a little bit on the passport model? And then there are two particular questions for you in the Q&A if you'd like to address those by typing an answer. But for our last question, can you elaborate a little bit more on the passport for access to data?
Yeah, I'm not an expert in it, but my understanding of it is researchers would be checked and say, well, you are a bona fide researcher, therefore we'll grant you authorization to use this data at large. And the reason I'm not totally sold on that model is because there is tremendous possibility that people would be excluded from this bona fide category, and they might have very legitimate research questions to ask. And the bona fide researchers too, some may get curious and not just use for their stated purposes and go beyond what would be their line of work, so to speak.
Thank you. This very, very informative and wonderful talk. I really appreciate the questions and the responses. And thank you again, Dr. Ana Machado. We'll have a panel discussion after our next speaker. I'd like to welcome Dr. Han Chow. Dr. Chow is a Schmidt Fellow at the Broad Institute of MIT and of Harvard. He uses mathematics, cryptography, and machine learning to enhance the information we can gather from massive biomedical data sets. Dr. Chow is especially interested in solving problems in the area of biomedical data privacy, single-cell genomics, and network biology. A key focus of his research is to broaden data sharing and collection in biomedical research by developing secure methods for analyzing sensitive data from individual participants. He works closely with the Broad's data science platform, and Dr. Chow received his PhD in electrical engineering and computer science at MIT. His advisor was Dr. Bonnie Berger. He also holds an MS in computer science and a BS with honors in computer science from Stanford University. Thank you so much, Dr. Chow, for coming today and speaking to us on emerging technologies for addressing privacy risk in biomedical data sharing.
Great. Thank you for the introduction. Hello, everyone. It's a great pleasure to be here and to be able to contribute to this conversation. So in this talk, I'm going to build upon what Dr. Ana Machado just presented regarding privacy risks, and I'll be honing in on those issues. These issues, as you know, impose various frictions in data sharing that motivate us to use these controlled access data repositories in the first place. And my goal today is to tell you about recent computational techniques that are being developed to help us overcome some of these privacy-related challenges. So first, I want to start by briefly going over our current understanding of privacy risks that we're facing. I'm aware this will be a review for most of you, so I will keep this brief. So the central issue to me behind all these concerns about genetic privacy lies in the fact that genetic sequence is the ultimate personal identifier. And as many of you know, only around 100 independent SNPs are enough to uniquely tag an individual. And this means that any traditional method for de-identification, for example, deleting certain fields from medical records, is going to require that we remove most of the SNPs from the data before sharing it, which of course is not going to be viable for research purposes. And there are many other properties of genetic data that make it especially effective as an identifier. For example, it has a well-defined structure that makes it easy to be compared between different samples. It cannot be replaced like passwords. And also beyond identifying a person, it can reveal phenotypic information about their health and biology. And lastly, privacy risks for an individual could also extend to their family and relatives due to shared genetic materials. So over the past decade, researchers have demonstrated a variety of ways in which privacy can be breached through genomic data. Our previous speaker also mentioned this aspect. So one key example is that genetic sequences are not only extremely unique identifiers, they can actually be used and be linked to real identities by leveraging information in public genealogy databases like GEDmatch. And this is done by querying the target genome against these databases to get a set of close relatives based on which one could narrow down the list of candidate matches. And by additionally combining this information with things like demographic information, it is possible to pinpoint a specific individual in certain cases. And of course, this is how you may be familiar with the news that this is how the Golden State Killer was caught. And the fact that this is possible is good news for criminal justice, but it does raise concerns about privacy. So what this implies is that when we share a genetic sequence, there is a reasonable chance that it could be linked back to the individual with some targeted efforts. We also know that even when only aggregate level information is shared from a database, like allele frequencies or association statistics, or even simple queries about presence or absence of a mutation in the case of genomic beacon services, if you're familiar with them, these data can also be compared against a specific individual's genome to infer whether the person was included in the database or not. And if the database is associated with a sensitive attribute like disease status, this could also be linked to the individual, leading to a potential breach of privacy. Beyond genetic profiles, omics data such as transcriptomics and metagenomics may also potentially be used as identifiers to link individuals across different data sets. And this is despite the fact that these data tend to be more noisy and not as reliable as genetic information. In addition, when there are genetic variants known to be associated with these other data modalities, also known as quantitative trait loci or QTLs, these known associations can also be used to infer a portion of one's genetic profile from these omics data sets, which could then be used for linking against other genomic databases. So when we think about privacy risks, we need to broadly consider different types of biological measurements beyond genotypes and how these different types could be linked to each other, potentially through the genetic sequence as a common reference point. And of course, there's still a lot we don't understand about the full extent of these risks. And considering that the quality and scope of many of these data sets are continuing to grow, we can expect that new risk surfaces will be discovered in the future. As we know, an important approach to tackling these privacy issues is through policies, regulations, and community standards for data sharing. Here are some notable examples that you're familiar with. Dr. Ono Machado also mentioned some of these. So this includes NIH Common Rule, which define IRB review, informed consent processes, HIPAA privacy rule, introduced the notion of protected health information or PHI. And I guess the most recent example is GDPR in the EU, which broadly governs the collection and processing of personal information for European individuals. And this also covers genomic and biomedical information. And so these existing policies and regulations provide necessary frameworks for us to safeguard the use of biomedical data, but they do come with limitations. One key issue I want to point out is that developing and enacting a policy is a slow and long-term process for a good reason, since they have broad and long-lasting impact on the community. For example, genetic data wasn't officially classified as PHI for HIPAA until 2013, which is a decade after the privacy rule was first implemented. And it is still not officially recognized as an identifier, at least in a legal sense. And this portrays a difficulty in keeping the regulations up to date in a timely manner. There's also the problem that in many cases, we just don't have the full understanding needed to design the most effective policies, which can lead to various ambiguities. For example, Both HIPAA and GDPR apply only to identifiable data, meaning that if the data is sufficiently de-identified or anonymized, then it is free to be shared without extra consent. However, there is quite a bit of ambiguity in where we draw this line. And this is especially a concern for types of data whose privacy properties we don't fully understand yet. And lastly, regulations for the most part serve to restrict the scope of data sharing by defining when and how the data can be shared. And they often do not address the core conflict between privacy and data sharing needs. So here's one main idea I have for you today. So if we think of existing data sharing mechanisms as a spectrum, on the one end, we have open sharing of data, which provides a lot of utility, but no privacy. And on the other end, we have not sharing the data at all, which is fully private, but not very useful. So existing data sharing mechanisms span the space between these two extremes. And by controlling the extent of scope of data sharing, they achieve some level of compromise between these two scenarios. Some examples here would be consent for different specific types of research, controlled access data repositories, removing certain data elements to reduce privacy risks, and data use agreements, which limit the ways in which the data can be used. Of course, all of these are very important tools for us. But it's also important to note that these solutions don't necessarily overcome the fundamental trade-off between privacy and utility. So my main takeaway for you is that there are emerging technologies that can help us break away from this existing range of solutions and help us design novel mechanisms that facilitate data sharing while protecting privacy. And these are what are called privacy enhancing technologies, which are a collection of methods being developed by security and privacy researchers in computer science and other related domains. And the hope here is that, as I mentioned, by leveraging these tools, we hope to design new data sharing workflows that can make it easier for researchers to share data across different labs and institutions and access them in a more interoperable way to help accelerate biomedical research. And I believe these techniques have a key role to play in our community and think that it would be useful for many of you thinking about streamlining the sharing of sensitive data to be aware of the tools that we have at our disposal. So in the next few slides, I will give you a very brief overview of each of these concepts. So first is homomorphic encryption, which is a cryptographic technique that allows computation to be performed over encrypted data. You're probably familiar with standard encryption workflow, where a piece of encrypted data provably hides information about the underlying secret. And this can be later decrypted using a private key to reveal the secret, but otherwise, this ciphertext is not used for purposes other than securely storing this information. In HE, on the other hand, this encryption method follows a certain mathematical structure that allows some operations to be performed over these ciphertexts that have a corresponding effect on the underlying secret. So for example, multiplying two different ciphertexts could have the effect of adding the two underlying secrets. So this way, just by manipulating the encrypted data, one could perform desired calculations on the underlying data set without having to decrypt the data first. So this allows sensitive data to be shared with other entities for computation purposes without having to share the raw data itself. Next up is secure multi-party computation, or SMC. Here, we also achieve the same ability to compute over secret data without seeing them. And here, this is achieved using a cryptographic framework known as secret sharing instead of encryption. The intuition here is to split a secret value into multiple shares such that each share is individually random. It doesn't leak any information about the underlying data, but all of these shares combined encode information about the secret. And these shares are individually distributed to a set of computing parties, hence the name multi-party computation. And SMC relies on interactive protocols between the computing parties where they jointly carry out computation over the underlying secret without ever revealing what the actual data set is. And at the end, these resulting shares can be combined to reveal the final analysis outcome. And again, throughout this process, nothing about the secret data is leaked to anyone involved. Unlike these two previous technologies, which are cryptographic ways of achieving secure computation, trusted execution environment is a hardware-based solution for it. So here I'll describe Intel SGX, which is the most widely known technology in this space. SGX is a hardware feature introduced in Intel Core processors since 2015. And these processors have this special ability to create a secure computing environment called a secure enclave that is isolated from the rest of the machine so that no other processes running on the same computer or machine can access or tamper with the data that lies inside the enclave. With this ability, a remote user could send their private data into a secure enclave through an encrypted channel, perform desired calculations inside the enclave, and then get the results back also through an encrypted channel. In this way, computation is performed over sensitive data without giving anyone direct access to it. There is an important additional feature of SGX known as remote attestation, which is a mechanism for these enclaves to generate a certificate to the user that proves to the user that the program that's running inside the enclave and its hardware configurations are legitimate. But even with this additional reassurance, it's important to note that security properties of SGX are not as strong as the two previous technologies that I mentioned, because it is based on assumptions about this secure hardware component rather than theoretical guarantees. But the fact that computation here is being performed over the raw data set inside the enclave makes this a very efficient approach compared to the two previous technologies. Now, all three of these technologies provide a way to perform computation over private data without revealing the raw data. And this can be useful for a range of different data sharing scenarios. So here's a couple of examples. The first is privacy preserving analytic services, where we have a private individual or researcher with genetic data who wants to perform some computation over it with the help of a third party who might have access to larger data resources. So normally, the user would need to give up their privacy to an extent by uploading their raw data to a server and trusting that the server won't be compromised in any way. But with secure computation techniques, we can design a workflow that keeps the user's data private throughout the entire process. Another use case of secure computation is multi-site study, where the goal is to run analyses on data sets across multiple parties without sharing the raw data. And this can be achieved by introducing a computing party or parties, in the case of multi-party computation, that can securely pull together the data sets in an encrypted form, perform joint computation over them according to the chosen technology, and then return the final result to the researchers to be revealed. And again, all this is done without leaking the private data sets to anyone involved. Unlike these methods so far, which focus on securely processing sensitive data, differential privacy, or DP, is a theoretical framework for mitigating the leakage of private information in aggregate statistics by introducing small perturbations to the data. And the main idea here is as follows. So when we observe a release statistic from a database of individuals, we can think about the probability of obtaining that statistic from different hypothetical databases. And if we have the guarantee that any pair of databases that differ by exactly one individual appear almost equally as likely based on the observed data, then intuitively we can say that any one individual in the database has very little impact on the final outcome of the study, and therefore we have some a rigorous notion of privacy protection for individuals in the data. So these techniques provide a way to achieve this type of formal mathematical guarantee by perturbing the statistic with a controlled level of noise. And this is in practice used by companies like Apple and Google to privately collect user statistics. And also recently, the US Census Bureau officially adopted this technique for the first time last year to mitigate the privacy risks in their data products. In the genomics context, DP has been proposed for releasing statistics like allele frequencies or GWAS statistics, but the level of required noise in many settings is often too high in order to achieve meaningful privacy, which is a key limitation of this approach. There are ongoing efforts, including in my own group, to address this challenge, And our hope is to make this more applicable for the sharing of genomic summary data soon. Lastly, I just wanted to briefly mention that there is also a branch of methods known as federated learning, which is also related to the distributed analytics that Dr. Ana Machado described. And this is a class of techniques for, in most cases, training machine learning models across distributed data sets. And the core idea here is to keep all the data sets local to each participating institution and share only the local model updates to be aggregated across different institutions. And this aggregated information is used to improve the global model, which is then distributed back to each of the institution to repeat this iterative training process. And because individual level data is not leaving each party, these methods provide privacy protection, but there is a caveat here. In many FL solutions, these local model updates are openly shared with other parties, which introduces potential privacy leakage. And in certain settings, especially when these models are, if you're talking about deep learning models with many, many parameters, high dimensional models, oftentimes these updates could be reverse engineered to reveal reconstruct the individual data points that went into it in certain cases. So this aspect needs to be carefully addressed when these methods are used by, for example, by using differential privacy. I should say that FL, in most contexts, is mainly concerned with the training of deep learning models. And because of that, relevance to genomics community might be somewhat limited at this moment, but I think it will be more relevant in the future as these models become more widely used. And there's already a lot of interest in applying this in the context of medical machine learning, especially for analyzing medical images, which often requires deep learning models. So I hope that gave you a good high-level understanding of what these techniques are about. So a major direction of my own research involves leveraging these technologies to support real-world workflows in biomedical research. And I want to give you a couple of vignettes of what these methods look like in practice. The first is about enabling secure collaborative studies. Here we use multi-party computation techniques to develop efficient protocols for tasks including genome-wide association analysis and drug target interaction prediction based on neural network models. And the key idea in both these works was to allow these tasks to be performed jointly across data silos while keeping the individual data sets private. So here's a little bit more detail about our secure GWAS workflow. So we have a set of data holders here at the top, which can also be labs or institutions. They first secret share their data sets with a set of computing parties. And again, this is about splitting the data into multiple copies so that no one has access to the raw data while still being able to compute over them. And once these data sets are shared, then the computing parties can run our protocol, which performs the GWAS calculations in a secure way. And at the end, the results can be combined to publish the final GWAS association statistics. So when we tested our pipeline on published GWAS data sets, we were able to accurately recapitulate the ground truth association statistics while additionally providing privacy protection for the input data. We also showed that the runtime of our protocol remained practical for large data sets, for example, around a week for 100,000 individuals. And these suggest that it is indeed possible to accurately analyze genetic data for certain kinds of tasks across different parties without sharing the raw data among them. At the moment, we are currently working on further scalability improvements, as well as extending these methods to a broader range of genetic analyses. The second example I want to share with you is about secure imputation service. So as you know, genotype imputation is a standard tool for enhancing the quality of genotyping data by predicting missing SNPs in the data based on a large reference panel. There are public imputation servers that allow users to submit their data to be imputed against a large reference panel privately held by the server. And here in this work, we asked whether we could provide a similar workflow with stronger security properties where the user doesn't need to trust the server to keep their data safe. In this work, we leverage Intel SGX technology to perform imputation securely inside the SGX enclave. In this illustration, you can see that the user is interacting with the imputation server by talking directly to the enclave inside the server machine. So the workflow is goes as follows. Very briefly, first of all, the user runs this remote attestation protocol that I briefly mentioned to verify the validity of the system that's being run on the server. Once that checks out, the user sends the encrypted genetic data that they have to the enclave to be imputed securely inside the enclave using our algorithm. And at the end, the results are sent back to the user also through a secure channel. A key challenge in this work was that we couldn't simply deploy an existing algorithm or an existing software tool for imputation inside the enclave, which would have been very convenient because of various limitations of the system, such as limited memory and the possibility of known security vulnerabilities. So the reason why I mentioned this is in many of these cases, being able to use these technologies require careful optimization and further algorithmic design. So just to give you a sense of what this kind of work entails, one main security threat to SGX is what's called side channel attacks, where an attacker observes external behaviors of the victim process, like runtime or memory access patterns, and infers private data based on these observations, even if they can't see the data directly. So here, for example, if a step in the program takes a different amount of runtime depending on a particular genotype that the user has, then an attacker who's just observing the behavior of this program outside the machine, they can potentially infer what the user's genotype is without actually being able to see the data directly. So in our work, we introduced algorithmic strategies to transform state-of-the-art imputation methods to guard against this class of attacks. And this resulted in a secure imputation tool that closely matches the performance of standard methods, while additionally enjoying enhanced security properties of SGX technology. I want to briefly mention that one of the goals that my group and some of my colleagues at the Broad Institute are working toward is to develop a cloud-based analysis platform for deploying these secure data sharing workflows based on the technologies that I described. And the idea is to build this on top of existing platforms like Anvil and Terra, which already allows researchers to create their workspaces, upload their data, and so forth. We think that a major bottleneck in the adoption of these privacy tools is the difficulty in grasping the details of these methods and how to set them up properly for each use case. So by streamlining the deployment process and providing a wide range of standard workflows that are easily configurable, we hope to encourage many researchers to be able to take advantage of these tools that are coming out. And also to mention a couple of other relevant ideas that we're currently working on. We recently designed a mechanism for selectively hiding sensitive loci in genetic sequences, such as disease associations, with minimal amount of masking required for privacy. As you know, hiding just one SNP is not enough to be able to really hide that information because there are correlations with nearby SNPs around it. So the question is, we have to mask a window around sensitive positions, but how much do we need to mask to have some level of privacy? So the hope here is that this technique will be useful for further increasing study participation among individuals who are concerned about specific loci in their data that are tagged with specific phenotypes. And we're also working on watermarking techniques for embedding unique codes into genetic data sets so that in the event of a data leak, we could trace it back to the entity that leaked the data. And this could be useful for introducing accountability in data sharing systems. Now, these are just some examples from my own work. And I want to note that there is a whole active community of researchers working on bringing these technologies to biomedical workflows. IDASH, as Dr. Ana Machado mentioned, for example, is an annual competition and workshop where teams around the world are developing these privacy-preserving solutions for a different set of problems each year. And yeah, there's still a lot of work to be done in this space, and there's an active community for it. There are key challenges that still need to be addressed as well for these technologies to be truly useful. First is that there is a gap between what the community needs and what the existing techniques enable. For example, crypto techniques like homomorphic encryption or multi-party computation that I mentioned, they come with considerable overhead for sophisticated calculations. So applying them to complex biomedical tasks often requires careful algorithmic optimization and engineering. And as I mentioned, many of us are working on closing this gap. Second challenge is that these methods are currently difficult to use because there are no standardized methods or software. Again, there are many ongoing efforts to productionize some of these methods. So I'm optimistic that this will be addressed in the near future as these methods mature. And lastly, we need policies and regulations that recognize these technologies and provide useful guidelines on how they can be used to overcome the existing barriers in data sharing. And for this, close interaction among those in technology, biomedicine, and law and policy is essential, which is why I especially appreciate being part of this conversation. So with that, I want to acknowledge my partners in crime who have contributed to various ideas I described in this talk. Thank you for your attention, and I'd be happy to take any questions.
Thank you so much, Dr. Chow. This has been a fantastic and really informative session, your talk today and the whole entire session. We do have a number of really good questions. I'll take the first one. How can we ensure that the infrastructure, potentially even the funding of the technologies that you discussed today can be taken advantage of by smaller, less funded institutions? So how can we democratize these really advanced technologies that you spoke of today?
Right, so at the moment that is a little bit difficult because most of these tools are being developed by research groups. They're not in a state where it can be widely used by many research groups outside of the community who are developing these tools. I think a key enabling factor there will be being able to access these tools and plug into your analysis on existing data sharing and analysis platforms like Anvil and also the STRIDE initiative that you mentioned earlier. So once these tools are incorporated into those environments, then I think there's really going to be broader opportunities for being able to use these tools. Thank you.
And Santa asked, are any pharma companies adopting these tools? Is there any industrialization of the approaches, or is this still all in the general research arena?
It is mostly in the general research arena. We do have some ongoing conversations with pharma companies who are interested in jointly analyzing data across, between different companies. So there is ongoing work, but nothing has come to the surface yet.
Thank you. This is a little bit more of a technical deep dive, and it has to do with the encryption, not just of X, the data, but also of F of X, the compute. So Chris asked, who determines when F of X must remain a secret and when it can be shared?
That's a really great question. There's a lot of nuances there. So yeah, it depends on what F of X refers to. On my slides, I use that to refer to the final analysis outcomes, say GWAS association statistics. So at that level, we need to release something to be of use to the scientific studies that we're trying to enable. So those are so those statistics will have to be shared. Everything in between the initial input data and the final product could be secured through the techniques that I described. But at the same time, even the final analysis output could leak privacy. As I mentioned, aggregate statistics can also be used for membership inference attacks. So at that level, if you want to provide additional protection, then we need to start thinking about, how do we perturb the data using, for example, using differential privacy to be able to mitigate those risks.
Thank you. Last question, I believe for you is, how is privacy by design achieved for data sets?
For data sets?
Yeah, privacy by design. Is there anything additional that you want to add from your seminar today?
Yeah, I wonder, yeah, I think the privacy of the data set comes into question when the data set is shared with another party or used for computation. So it's not a property about the data set itself, in my mind at least. It's about all of the stuff that comes after it that allows the data to be used by researchers. And so if we design frameworks for that part, the computational frameworks that are secure by design, I think that makes the underlying data set safer.
Thank you. We have time to bring back our speakers. Dr. Ona Machado, if you'd like to join us, we can have questions that our speakers can address. And I can lead off, while people are thinking about questions, I can lead off with the first question. As you know, our genomics data sharing policy has some pretty high bars for data sharing and data aggregation. So in the work that you're doing in privacy preserving or a federated compute, how can we create those aggregated data sets that could be, for example, genomic data with electronic healthcare data, which might provide a very rich data set for investigators, yet still maintain our strict genomics data sharing policy? I don't know if you want to take the first shot at answering the question, Dr. Chow, and then I can pass it off to Dr. Ona Machado.
Sure. Yeah, so this question about being able to jointly leverage different types of data sets across different institutions, I think one opportunity that is unlocked by the techniques that I'm talking about, that I was describing, is basically being able to keep these data sets local within each institution and be able to have a layer on top that sends the computation to the local sites, and without actually pooling all of these private data sets into one place. So I think in that sense, it could help with that challenge.
Thank you. Dr. Ona Machado, do you want to also address this question?
Yeah, I agree completely, because once you lose control of the data, you can't tell what it was used for. And even if it's done only as an after the fact thing by log analysis or some other ways, it's better that you keep local control of the data. Nothing is perfect, and I want to emphasize what Dr. Cho said in one of the slides, that it's the pairing of the policy and the technology that will win. It's either one separately will not do it.
Thank you. I think we completely agree. There's a really great question, which we haven't really touched on today too much, which is the sharing of private information by individuals on social media or similar device spaces. I don't know if you want to talk a little bit about the question whether privacy is truly tenable in our now digital era.
Well, let me start with that, because I think it is to a certain boundary, right? It's not perfect, but you can mitigate, you can make it as small as possible. What people perhaps don't know when they're sharing so much information on social media is that can be linked to so-called de-identified data and make it way easier to re-identify individuals. So people, I think, are still unaware of the broad consequences of it. And also we know that patterns of privacy preferences change over time, and depending on the data and depending on circumstances and so on. So I think, you know, privacy is dead. No, you know, it's not. I think there are things we can do.
Thank you. Dr. Chow, would you also like to address the linkage of social media data to other types of more controlled access data?
I think one meaningful distinction there is the data that we're talking about that are on social media. It's something that's voluntarily shared by the individuals, right? So by letting people know more about the privacy risks of sharing personal information on the internet, I think we can partially address that question. The research data that we're discussing here is slightly different in that, the patients can sign the informed consent and the data goes somewhere, and then they start losing control over how the data is being used or like who it's being shared with. So that's the part that worries me more about this privacy question. Yeah, when it comes to social media data, I think there's more we can do about that.
Thank you. This might be a question more for you, Dr. Chow. It's the overhead of the fairly computationally expensive homomorphic encryption. Do you want to talk about how that can be reduced or overcome?
Yes, right. So I didn't really go into the technical details, but it is quite expensive to use. And that's why these techniques are often limited to doing simple computations, linear operations mostly. But even with those limitations, it is still useful for many tasks, like training linear regression models or logistic regression, like Dr. Machado mentioned. So there's still a lot of value in these techniques. And I should also mention that HE techniques, these are being rapidly developed by the cryptographers, and it's getting faster and more efficient every year. So there's reason to hope that in the near future, we'll be able to apply these tools for a broader range of analyses.
Thank you. Could both of you speak to the potential feasibility of using blockchain to track how private data is used and where it goes? There might be some real opportunities there for using blockchain in new ways.
I think this one's for Dr. Machado.
Would you like to talk about that, address that, Dr. Machado?
Yeah, I think the beauty of the technology is both in being immutable, in partner with that being public, right? Or no one owning that database. Everyone owns the database. And once you put something, transaction that happened, someone got this private data, no one can tamper it and say, no, we didn't, or change the database underneath it. So I think in terms of documenting what was done, who was done, and even releasing the data or not, in my opinion, the smart contract part of blockchain is less known than the immutable ledger part of blockchain, but that too, the smart contract could be used in this data transactions. I'm fully an advocate of using this technology to keep track of data provenance, of attribution, data attribution as well. And having this, it is a means to reconstruct what was happening, and added to techniques such as the watermarking that Dr. Cho referred to. I think the combination of these techniques, we are so lucky to be in an era where we can use all of that, and we should be using more.
I completely agree. So there's an interesting question from Dr. Wagner. In computational methods that prevent access to the underlying raw data, how do you examine and validate the models of those methods? And then there's a follow-up in terms of when you want to include or exclude very particular variables, how do you compensate for that in your regression models?
Yes, this is a great question. So currently, most of the methods that are being developed, it views the entire computation as one block and gives you basically a black box that you can run that feeds in private data, spits out the final results. Nothing is leaked in between. So if we want to have this more of an interactive experience where we explore the data set to discover which variables we want to use, what parameters to set, do we need to look at a subset of the data set for the analysis? So all these questions, if these need to be answered, then we need to modify the black box so that we can introduce points of interaction with the researcher, so that instead of having one black box, we have different components and modules. And within each module, nothing is leaked. But when we do need to look at the data, we can release some information and the researcher can make decisions based on those. So it is possible to handle this type of interaction.
Thank you. Well, we're nearly to the point of our closing. I can give folks maybe one more minute. Potentially last question. Okay, so this may or may not be for NIH. Does controlled access data at NIH include data on NIH grant applications? No, no, not in the context that we're speaking of today. I think hopefully that addresses your question, Dr. Marbury. Well, I want to thank all of our speakers for a really, really good session. I'm going to turn it over to my colleague, Dr. Brennan, who is going to close us up and tell us what is going to happen next. And I hope that all of us who are participating today will continue to stay engaged throughout the summer as we do explore streamlining controlled access data. Thank you so much, Dr. Brennan, for closing us up.
Thanks very much, Susan, and thanks to all of our presenters and the great questions. This has been a really amazing session. My challenge is to try to summarize the session, and I have to say we could spend hours longer on the summary. There were so many interesting aspects presented during this conversation. But I want to begin first by acknowledging that our colleague, Dr. Anna Navaz-Asian, did have to leave, and she's apologized for her technical difficulties. She actually didn't understand what was happening at the time. But she asked me to relate to the group that she, at the point that we lost her video feed, she was commenting on the importance of tribal research boards, that they can provide important feedback that allows us to improve the science. But occasionally, the research may not get approved because of a disagreement or concerns about the tribe. And she was reflecting on a specific example about a time where there was a desire to test water samples in a community. And there was a debate at the tribal level, and that ended up with restricting water sampling for only from well water, not for the general groundwater. So the conversations have to be approached as a conversation and with a level of mutuality, not from the perspective of presentation and response. Anna also is encouraging you to contact her via email if you would like, and her email address is at the bottom of this page, an2737@columbia.edu. So please feel free to reach out to her. We had a terrific introduction to some of the most important concerns from specialized communities in her presentation. I want to thank our CDAC working group. The Controlled Data Access Committee working group is a set of volunteers drawn from across the NIH. And it is because of the people that you see on the screen in front of you that we were able to have this summer of understanding controlled access and streamlining access to controlled data as rich as it is. This team has met mostly monthly, sometimes weekly, to put together invitations, to put together plans, and their efforts have been really, really, really effective in bringing this group together and coming forward. They represent all across the NIH. I want to particularly thank Hillary Leeds from our Office of Science Policy. Hillary is our primary executive on this project, and she has helped us to bring things together. She's helped us to keep moving with this complicated area and to make it manageable enough for us to be able to have conversations and be able to take the kind of steps we hope to take after today's meeting. I'm taking away a couple messages myself. I want to actually pause and have each of you think about the messages you want to take away. And specifically, if you want to add a few into the Q&A now, that would be a really appropriate thing to do. We heard 4 different presentations, and they brought a number of different perspectives to us. The presentation by my colleague, Richard Hodis, was a terrific way to start off the day. Susan and I were very grateful to Richard for his willingness when we asked him to step up to provide this presentation, because getting the perspective of why NIH cares about this streamlining access from someone who's a research leader like Dr. Hodis was particularly important. I took away the message that one size does not fit all. That is, the strategies for streamlining access have to be in part tempered by what the purpose of the access is. Is it to read contact permissions? Is it to manage the withdrawal of the permissions that a participant has given in the past? Is it to match with new data, for example, the CMS data? And I saw in one of the questions earlier, wondering whether NIH was going to be sharing some of the linked data sets that they have been undertaking in certain projects. And I want you to know that is an active discussion right now. And the conversations, each time we add another layer about extending access to a data set, we have to go back to understand the original consent. And that was a very important part of Richard's message. The other part of his message that I think is really important is that the technology is allowing us to do many new things that definitely enriches scientific impact, but also brings about much more complicated questions and ideas related to how we're going to manage the rights of individuals and advance science at the same time. The kinds of questions we're having now, the ability to link disparate data sets or data sets that are disparate over time, is really an enormous opportunity for new science. And we have to make sure our policies and our reflections on these access to these data keep up with the technologies that are available to do so. They appropriately tempering the conversation from Dr. Hodosa was the presentation by Anna regarding the Indigenous community access. And what was critical, and I think is really largely undocumented in our data access forms, is this concept of community consent. That is, the access and use of the data has to be managed on two different levels. We come from a tradition in the biomedical sciences in the US that largely focuses on individual consent as being the primary and sole indicator of use and access. But Anna stressed very strongly, community consent is also critical. She spent a good deal of her time, I thought, discussing helping individuals understand what will be done with the data. And one of the challenges we have here, especially with post-collection access to existing controlled data sets, is that the vision of what might be done with data sets is not always known when the consent for access to that data set is obtained. So we have to be sure we are providing the proper information at the point of consent and have a strategy for addressing modifications to the request after the data has been collected. I found that the considerations that Anna was bringing forward are actually similar to the considerations that all participants have in data sets. But as we heard throughout the conversation today, that it isn't just the individual, it might be a parent, it might be a sibling of the individual that also has a vested right in understanding what might be going on with data sets. These are new questions that will continue to require significant interactions, both from the standpoint of NIH as a research community and a funder, as well as the broader scientific and public community. Anna stressed the importance of balancing access and control, understanding how to make sure we have technologies that support the integrity of especially tribal communities with the right to control access to their data and do it in a way that is efficient for them. The time spent by volunteers from these communities in IRBs and in data access committees is not free. It's the time that they are giving from their lives, and we must respect that and build technologies that allow us to support their efforts. The takeaway messages I took from Lucila Machado's talk really focused on this very sophisticated and, to me, some very new concepts about the analytical tools to both record consent, make sure that consent is implemented properly, and to represent consent in a way that actually assists not only with the access, but also the authorization to use a data set, understanding the flexibility that's needed, understanding the time constraints that are on this. It touched on in a way that I thought reflected the 15 years of expertise her team has on different ways to address and respond to the risk of re-identification. And I saw, again, questions in the Q&A wondering what risks were we really worried about? What is the risk? Is it individual exposure? Is it the possibility that an individual will have some sanction or have a restriction on future activities in their own life, access to insurance, for example? Excuse me, I think better elucidation of what the risks of re-identification are relative to not only the data set, but the intended use of the data set is going to become an important part of our future. Lucila also raised the question of the ethics of not sharing and the ethics of sharing, understanding particularly in the time of a pandemic, the challenges of keeping data secure and the challenges of learning what needs to happen and what is unfolding in a public way are really at odds with each other. And she introduced us to the concepts of privacy preservations that has both institutional and data-centric strategies. That characterization, again, I found quite helpful. And a terrific lead into Dr. Cho's final presentation on the emerging technologies for addressing privacy risks. The privacy enhancing technological solutions take us beyond the trade-off between privacy and utility. How much do we have to preserve the privacy of this individual or group? How useful will it be to have this data? And he identified strategies such as distributed analytics, differential privacy strategies, and other computational approaches. The key insight that I took away from his comments was that privacy is not solely a characteristic of the data access and its storage, but also a function of the analytical operations that are proposed to be used with that data set. So I believe as we take this learning forward to our discussions here at NIH, we need to move beyond thinking how we're going to keep this one data set as secure as possible and used in the manner it was intended, to how we're going to expand that to look at how we consider both analytical strategies as well as data access strategies. We need to keep this conversation going. Susan and I were charged by the Data Science Policy Council to spend a year thinking about how to improve or streamline access to controlled access repositories that the NIH holds. This workshop today has been the first step of activities that are going to continue through the summer. The webinar has been recorded and it will be shareable through the NIH Data Science website within a few days. We have some responsibilities to make sure that the recording is accessible, but it will be up shortly. Next, though, we're going to have a series of breakout webinars based on the conversations that we had today. There are 3 scheduled. They are scheduled over the next 2.5 weeks, July 22nd, July 26th, and July 28th. Each of these breakout sessions has a separate registration required. The first will be addressing making controlled access data readily findable and accessible. The second will focus on general opportunities for streamlining access to controlled data. And the final will focus on addressing oversight, governance, and privacy issues in linking controlled access data from different resources. Each of these are now open for registration on our website. We encourage you to continue the conversation through these meetings that will be coming up over the next few weeks. We also have released, as of today, a NIH request for information, streamlining access to controlled data from the NIH repositories. This request for information is a very common way for NIH to approach getting more community input. We hope you, your professional societies, and your institutions will respond to this. The NIH is requesting input on the strategies that can be used for harmonizing, simplifying, and streamlining mechanism for accessing data within the NIH-supported controlled access repositories that will continue to uphold robust privacy and security protection. We want to particularly understand the researchers' experiences in finding and accessing the controlled access data and determine whether or not our existing policies are adequate to address the aggregation and linkage of controlled access data. I think we heard today several indicators that we may not have the policies in place that are broad enough and robust enough to address this. So your input is sought on this critical area. Input will be provided, access to the RFI can be had by going to the data science website. That's datascience.nih.gov. I want to stop here now and thank you for your participation. Over 350 people were involved in the webinar during the day, and I'm sure we'll have opportunities for individuals to view it over the next couple of months. Your input in this important conversation is extremely important to the NIH. In the future, we will be looking to find ways that the NIH can better support effective reuse of research data that preserves the rights of the individuals who contributed that data and protects them from inadvertent risk. I'm going to now turn back to Susan for the final thank you to say, but all of you have a very safe weekend and enjoy a little bit of summer.
Thank you so much, Patty, and thank you particularly to Hillary and all of our working group members at NIH. This has been a fantastic webinar, and it's just the kickoff for a number of activities this summer. Our speakers today, my colleague, Dr. Hodes, Dr. Ana Navarez-Chen, Dr. Lucila Ona Machado, and Dr. Hong Chow were just simply fantastic. And the conversations really do help elucidate some of these challenges and opportunities that we will be exploring later this summer. So I want to thank you and to our participants, and I hope you have a wonderful, wonderful rest of July. And I hope that you'll also respond to some of our requests for informations and join us in additional webinars.
Susan, let me just point out that there was a